Well, good morning, everyone. I'd like to welcome you to today's roundtable on the procurement and deployment of vaccines for researchers. I'd like to welcome our panelists who agreed to assist us on this roundtable. And I'd also like to welcome our external members and MRC staff that have joined us, together with the South African Medical Research Council's Bioethics Panel. So I'm Amos Dlamini. I'm chairman of the South African Medical Research Council's Bioethics Panel, which is located in the offices. There is some interference, and I'm going to ask that all of you please try to mute yourselves. So I'm chair of the South African Medical Research Council's Bioethics Panel, which is located in the offices of the President and the CEO of the Medical Research Council, Professor Glenda Gray. Now, just by way of introduction to the program, a vaccine procurement and delivery has to be carefully managed. And currently, we're faced with huge resource constraints, both with supply and financial. And yes, this will therefore justify a phased approach. The constraints are even greater now when we see the results of the AstraZeneca vaccine, the efficacy study. But does that have to set us into a panic mode? And I think we just need to look at the results objectively and work with our scientists on how we can move forward on vaccine procurement and delivery, including use of the AstraZeneca vaccine. When we look at our research personnel, and by research personnel, I mean everyone involved in research. So not only the researchers that are out on the field in contact with participants, but our PIs, co-PIs, research coordinators who may not be in contact with participants, together with our receptionists, our drivers, etc.
Amos, did we lose you? Did we lose Amos?
We lost
Amos.
Amos.
Me? Okay.
No.
Muted. Go ahead, Amos.
Someone muted me. So
sorry. But you have to start over again, Amos, then. We never heard you in that last bit.
Sorry. Okay, so someone muted me. So let me start again. I don't know where you lost me, but I'm Amos Dlamini. I'm chairman of the South African Medical Research Council's Bioethics Advisory Panel. And I'd like to welcome you to this round table on procurement and deployment of vaccines for our researchers. Now, a vaccine procurement and delivery strategy must be carefully managed. Why? Because we have severe resource constraints, both in terms of supply of the vaccines and financial. And therefore, obviously, this will justify a phased approach. Now, the supply of vaccines has become even more acute in terms of the results that we see from the AstraZeneca vaccines. And we're all aware that 1.5 million had been planned for deployment with our healthcare workers. What I'm going to suggest is we should not go into a panic mode, but we should leave it to our researchers to guide us through how best we could use the AstraZeneca vaccines in any deployment strategy, whether through research or otherwise. Where are research personnel in this phased approach that's been worked out by the Ministerial Advisory Committee. So we do know that healthcare workers are in that first phase, and they were going to receive vaccines. And I believe that despite the issues with the AstraZeneca vaccine, the program is still going to be on track. So our researchers, anyone who's a healthcare worker, registered with a health statutory council, will be included in this phase 1 of the phased approach. But is it going to work that easily? Is that rollout going to be that easy at this moment in time, considering that we basically are not totally aware of whether we're going to get an adequate supply of vaccines for all our healthcare workers. Now, when we look at research personnel, we don't actually look at researchers that are on the field itself, having face-to-face participant contact, but we're also looking at all other researchers. PIs may not have face-to-face contact, but what about our drivers, our administrators, and others? I think there's some disturbance again on the line. I'm going to ask that all of you please mute your cell phones, your Teams app. So, so there are others involved, and where in the phased approach are the other research personnel going to fit in? And we do know that research is pivotal towards delivery of any product in terms of research and well-being. So I think it's important that we do have this discussion. Yes, our government has gone ahead and is going to provide for the country at large. But the question is, how can we, from different aspects, get involved and assist with this procurement? So this morning, we've put together a very good panel that are going to answer certain questions that we've posed to them. And, the questions that we posed are: should sponsors and research entities contribute or cover to the vaccination of research personnel? Could this be considered their responsibility? And if so, why should it be their responsibility? How would we define who research personnel actually are? What should the approach be in light of the variant that we have in South Africa? Could this take the form of an implementation study similar to the one proposed for healthcare workers with the J&J product? Do our researchers envisage any impediments to a rollout to research personnel? And if so, what could the strategies be that they would recommend to us to address or overcome these envisaged impediments? To our ethics person and I will introduce her just now on the panel. To the above, we ask her what would the ethical considerations be with what we are discussing. Could this be considered as queue jumping, bearing in mind that the vaccines that would be procured for research personnel would not be coming from the pool procured by the state? And with the latest developments on the South African variants, could the AZ vaccine be used in the context of well-designed studies with highly motivated and literate participants, like researchers and other professionals? What would the ethical considerations be? So, on our team this morning, I'm going to ask you again to mute. So on our team this morning, we've got a strong team. We've got the chair of this program, who will take over from me now and chair the panel discussion, and that's Professor Salim Abdul Karim. I'm not going to introduce him. He's a household name. He's not just a name with scientists, but he's a household name. And believe me, all my relatives discuss him during dinner time, his dinner time talk. So just to say, he's director of CAPRISA and one of our global research leaders. So he's going to chair our panel discussion. And our panelists are Professor Glenda Gray, who is also a household name. And she's also part of dinner table discussions at the moment. And just to say that she's president and CEO of the South African Medical Research Council and also a global leader in terms of research. We have Dr. Matsonso Matubela, who is from the Sefako Makgato Health Science University. He's a public health researcher and also very much involved in clinical trials research. So he's going to speak to us from the heart in terms of how should researchers view this in terms of procurement and deployment? And we've also got Professor Ian Zahn, who's the director of the Right to Care. And he is a well-known PI on several clinical trials. He's with the Wits University. Also with Wits University is Dr. Mantu Mokachane, who is a neonatologist. She is also the director of the unit of undergraduate medical education at Wits Faculty of Health Sciences. She's with the Wits Research Ethics Committee, has huge experience on various ethics committees, and she's also a member of the South African MRC's Bioethics Advisory Panel. So we've got quite, I would say, a strong team of panelists. And I'm going to now hand over to Professor Abdul Karim to take over the panel discussion. Over to you, Slim.
Thank you very much. I had to find, I have to say, I'm not as au fait with this Microsoft Teams as I am with Zoom. So please forgive my delay. Wonderful. Thank you very much. And it's wonderful to be here. And I have to start on a note that if there's going to be a hot button issue in ethics, you have to anticipate that there's this certain somebody who will find that hot button issue, and she will stir that pot. And that is none other than Dr. Amos Dlamini. I love the way in which she looks at these important issues, deals with them, brings people together, and tries to find a way forward. So Amos, thank you very much for bringing us all together today to engage in this important deliberation. So we have a terrific panel, a panel that's going to give us a range of different insights on the fundamental question we are here to discuss today. So what is it that we want to end today's deliberations on? We would like for us to develop some kind of clarity and common understanding of whether research, what shall I call them? Research staff, research teams that are undertaking COVID-19 research, what is the obligation that sponsors and research funders have to providing these individuals with COVID-19 vaccines? This issue only comes about because there's a scarcity of the vaccines. We don't have them readily available. You can't just go around buying them. So it's a time-limited problem that we have during this period of scarcity. but it's within the context that research personnel doing COVID-19 studies are placing themselves at risk for the greater good. And when they're placing themselves at risk, is there a certain responsibility that those of us who are supporting that research, funding that research, what obligations do we have, or what should we be doing, even if it's not an obligation? So that's the question. It comes about because research participants have a much more clear-cut situation. They've participated in the research, and at the end of the research, there's an ethical obligation to ensure that all individuals have access to the vaccine that is effective, whether it's the one that was in the study or in some other study. Now, whether that should be extended to research personnel is what is at issue. Because the issues about risks and benefits are different when it comes to research personnel versus research participants. So that's the question. We have a terrific team here to help us grapple with this question. I'm going to invite each of them to share their perspectives, and at the end, I'm going to try and give us some clarity about where we are, and I'm going to invite all of you to participate by sharing your thoughts, asking your questions, and contributing to the overall debate that we want to engage in today. We are scheduled for 2 hours, but I hope we will be, if we are efficient, we should be done well before that time. Okay, so on that note, I'd like to start by inviting Professor Glenda Gray, who is Big Cheese. She is the person who's leading us in our battle against COVID, and she's the one who is leading the research activities in the Medical Research Council. So as president of the MRC and CEO, I'd like to invite Glenda to share her perspective. Over to you, Glenda.
Thank you. Thank you, Slim, and thank you, Ames, for taking this initiative. Ames, I hope we don't give people indigestion at dinner. I hope there's lots of antacids and that the food is not too spicy, because I think you could get you could have a lot of heartburn if you're discussing us at dinner. So hopefully you're discussing us when you're having dessert, and the ice cream can ease your stomach and your heartburn. So good day, colleagues. This is a very important topic, and I'm very glad that we're going to discuss it, because I have been inundated by requests from research personnel to ask me whether they would be able to access the rollout of vaccines from the government rollout. And obviously there was concern, and it was tricky because they don't have personal numbers. They're not really in the private sector that's been allocated slots. So we kind of find ourselves finding ourselves in the cracks about this. And a lot of the research staff, be you a field worker, a driver, or a healthcare worker, or receptionist, have in this last year kept the research clinics open and have stepped forward to do COVID-19 related research, and have put themselves very much in the front line, as much as their frontline healthcare workers who have been doing care. And so we find ourselves in a situation where the researchers who helped assist to understand the value of vaccines in our country may find themselves in a position where they don't know where they fit in terms of access, and whether they're going to be the last people in the queue, or whether they have to wait for their age and comorbidity issues, or whether there's a strategy to include them. So there are a couple of mechanisms, and we have been thinking of, so since we've been getting these discussions, we have raised a couple of strategies. So at a global level, we've been collecting the names of all researchers who've been involved in COVID-related research from Latin America, Southern Africa and other parts of the world that are outside the US that have been involved in COVID-related research. So we've started to collect all the names of all the research staff in a discussion where we, as a global collective, may either be able to participate in some kind of program that will, one, give access to researchers as well as help further evaluate the vaccine, much like an open label access study. So that is one of the strategies we've been discussing. The other strategy is obviously to access the government rollout. And then the other situation we find ourselves in, obviously, whatever we negotiate in South Africa, we have to realize that we have compatriots and scientists in the rest of Africa. And we find ourselves one day having a call about access, and the researchers in South Africa talking about their desire, and the Malawians and the Zimbabweans and the Zambians on the call said, please don't forget about us. We're also part of your research program, and we don't want to be left out. And so whatever we negotiate on behalf of ourselves as a collective, we should also consider in programs outside our country, how we can help other people at a global level. And then we also have the other situations that are also recently faced, is that we have people who work in South Africa who are affiliated to US institutions, and these US institutions are vaccinating their staff. And I got a memo requesting me to that there's vaccine available for these staff members in South Africa, and how do we facilitate their access to these vaccines, because they know these people are not, they may not be South African citizens, they may be American scientists who are on the US university payrolls and can access vaccines, but they find themselves in South Africa. So that's the third dilemma that we face. How do we deal with people from other institutions outside South Africa who would have had access to a vaccine had they been in their country? Two, how do we help the global science endeavor to access vaccines? And three, in South Africa, how do we address this issue in the context of a government rollout? So those are the three issues that I face, that we have been faced with in the last couple of weeks. Thanks, Amos.
It's over to Slim now. Slim.
Thanks. It takes me a bit of a time to find the place to unmute. Thanks very much, Glenda. Really to the point. I think you've captured for us some of the key issues we're going to have to grapple with in this discussion. So next, I'd like to invite Dr. Matabula to share his thoughts with us. He is the head of the campus health unit at Sefako Makgato Health Sciences University, and he's got a long-standing interest in public health, ethics, sports medicine. So wonderful to have you, Dr. Matabula. Please go ahead.
Thank you very much, Prof. Karim. Thank you very much, Amos. And thank you, Glenda, for putting together this whole conversation. I think it's critical that we, at this time, should probably engage on these issues. But just to make the point, and I'll be very brief, I just want to make 2 or 3 points. And the points I want to make all center around what it is that defines our ethical behavior when it comes to the distribution of vaccines and other remedies. When you look at the whole issue of procurement, you realize that it's a different discussion because there are people with different interests that come in. But procurement for the purposes of making the vaccines available and accessible to people, we ask the question, what is it that is at the center, or that is the source of our ethical behavior in this case? And I want to, just one thing, I want to suggest that at the core of it all is our interest in the respect for life. So if we have an issue with the respect for life, we then say, how then do we make decisions around making available and accessible medical interventions that will save lives? Researchers, in particular, are people who actually interface with these investigational products. Now, can you imagine a situation where you administer a vaccine to a participant when in fact you yourself are infectious? And you probably have not tested, you don't know your symptoms yet, they will develop tomorrow, or they will develop a day or two later, you know? So the debate around whether researchers should actually receive the vaccine as well is fundamental. If I was a sponsor of a particular vaccine, and at the end of it, I find that it had 80% efficacy, when during the trial itself, I allowed my members of staff who were participants, or not, who were not participants, who were actually staff in testing the vaccine, having had a few of them die, I'm sure at the center of my heart, I'd have a problem with, was I ethical in my behavior if I don't make this vaccine accessible to them? So the argument, therefore, is researchers themselves need to have access to these vaccines. I have no doubt. How do I define researchers? I am just thinking, just from a rhetoric point of view, I could ask a question. We had how many months or how many weeks of lockdown? And who did we define as an essential worker at that time? There was a conversation that the garbage collectors are actually very essential people in that case. So can you consider the driver not to be a research worker? Can you consider the cleaner on the clinic site not to be a research worker? Will you overlook the gardener who has to maintain the grounds, not as an important person in this case? If you look at our hospitals, is the lady who mops the floors not as important as the doctor when it comes to protection against COVID-19? And I think COVID-19 has forced us to think about the nature of the illness that we have to deal with and the investigational products that are there. When we were doing tests to determine if antiretrovirals were effective and efficient, people saw those that were taking the medication with severe side effects, and they were happy to stand by and say, I do not want this illness. But COVID came and they say, hey, I don't want this illness, but I want the product. So the challenge and the discussion changes and shifts completely. So we need to look at what it is that is at the center of our ethical conduct and behavior and ethical decision making. Our interest is the saving lives. Now, COVID knows no color, it knows no barriers, it knows no race, it knows no creed. It does not respect economies. And so we can argue that how do we then prioritize who gets the investigational product? Who gets the vaccine first? And I would imagine that there will be different layers of debate when we talk about who exactly should get it first. Now, whether the researchers should get it first or the politicians should get it first becomes a debate. But I would recommend and I would suggest that as a person who, let me start at this level. If I was a participant and I was getting a placebo, definitely, there is no question. If that vaccine is effective, the placebo recipient has to get the real stuff. That placebo participant needs to get the real deal. They must be vaccinated, and that clears that out, because then you will be demonstrating goodwill and showing how you do not use them to get answers to your questions. Number two, the people that are then the research workers in that facility, from gardener, from the guy at the gate, right through to the one who administers the vaccine. All of those people are part of the same system, and you cannot start ranking them at this time just because now the product is known to be efficacious. I would not think that would be ethical behavior. For me, my argument is that should this fellow at the gate not do his job, you will struggle also with your job, even in managing what goes on in the center. If the researcher or the staff that are clinical in the investigation are considered to be more superior than the others, then we will have a problem, because then the ranking talks about those that are better off and not. And this is the issue about who gets the vaccine first. You know, the whole queuing thing brings in a power dynamic that should not exist, because everybody has a view from where they sit. The poor and marginalized have a view because they will say, no, we are not being reached, we are not being given because we are poor and marginalized. The rich will say we can pay for this. It's a view, and it all boils down to the same question. What is the source of your ethics? What is it that drives your ethics? Now, I really think that sponsors should take responsibility. They should take responsibility to make sure that the people that work in that research facility do get the vaccine as part of their outreach and as an acknowledgement of the effort that researchers put into doing the work. Otherwise, the earning of a salary is not enough to define a commitment to the welfare of your people. I can give you an example that we have had situations where at one point we were not even sure that we will have people coming to work, because at the peak of the pandemic, a lot of people were getting infected, and some were becoming contacts. And in order to control the infection in our area, we needed to separate people and to refuse people coming to work and so on. So if I could have made it, I would have put people up for vaccination a long time ago, just to make sure that none of them are lost to the work and the good work that is done by researchers. And then maybe finally, I can say that there are a lot of things that may happen as we try to roll it out to research workers. They are human. They will behave like human beings. Some of them know that we do get a flu vaccine every year, and others still make the decision that no, I'm not getting that flu vaccine. We have no decision, we have no choice over how they behave. So many of the impediments that we may find, we shall be able to then deal with them as and when we get to them. But I think at the core of all that we need to do and say at this time about researchers having access to the vaccine itself and making it the responsibility of the sponsor. Make it the responsibility of the sponsor, because they are actually part of the team. And it is in the sponsor's interest to make sure that their people are protected from this infection. Thank you very much, Prof.
Thank you very, very much. So I like the way in which you sort of put it center stage, that we're about saving lives, and then everything stems from that. And I think you very nicely captured the way in which research personnel are engaging in risk and the benefit. And and who is responsible, you touched on as well. So great, really appreciate those comments. Next, we are indeed honored to have in our midst Professor Ian Sun, who, for those of you not familiar, runs an organization called Right to Care. So who better to ask to address the very question of, do research personnel have a right to get ahead of the queue and come right up front to get COVID-19 vaccines? Over to you, Ian.
Thank you, Slim, as always, very kind. So I think I agree with most of what's been said up until now. I do think that there are a couple of elements that I would like to add to this. So in general, we have a waterfall of access to vaccine. If there were unlimited resources available, we would not be having this debate. The question then arises, in which rank order priority should we be dispensing this vaccine? And I think across the society as a whole, we've agreed that the balance between the COVID epidemic and the healthcare system is a balance that we wish to improve to enable the society to increase movement and start practicing economic activity. So I think nobody is going to debate that healthcare workers need to be high on the rank order of rollout of vaccine. So then the question arises, the specific question we're addressing today arises whether the research site personnel fit into that category of healthcare workers. My understanding from the data available from Treasury that defines the populations of healthcare workers and other industries in South Africa is that we're probably dealing with about 1,500 1.5 million persons in the country that define themselves as healthcare workers. And so that's the target for the first phase of vaccine rollout that we wish to target. There are two categories, and I think researchers is one of them, but the non-profit entities and who provide with donor support to the health system, particularly in South Africa for HIV tuberculosis, is a category of staff that we also need to consider. And I believe that as we debate healthcare workers, we definitely need to extend to the frontline workers that are engaging with our population, our patients, including community healthcare workers that even are being asked to go door to door to do contact tracing for COVID. So there's an expanding pool of people that we need to consider. In South Africa, most of the COVID research has been conducted by research units that have been involved in HIV and tuberculosis research for quite some time, including all of the panelists have been involved in these research units. And my sense is that the debate today also needs to realize that those units are not only involved in prevention COVID research with vaccines, but indeed also in a body of treatment research where the staff will be faced with known COVID positive patients, bringing those on to either repurposing studies such as the Crown study and solidarity studies, or in fact monoclonal antibody studies in the near future. So I would argue that researchers are not, and even our laboratory colleagues need to be considered. So another group that I would like to include is our laboratory colleagues that are doing the basic sciences work on COVID, often working with the variants, or potentially, in fact, doing the diagnostic work for the clinical trials. So there is quite a substantive population that needs to be added back into this first category of staff. There's no doubt that we agree that participants in research, I think all ethics committees would agree that a participant who's been included in a study that where there's a successful outcome, that we have long-standing precedents from the hematopoietin studies in renal dialysis and the HIV studies, antiretroviral therapy studies, that the group that was in the control arm should be provided early access to the intervention. So I think that category, all researchers are aware that they indeed need to deal with. Then it's the question of the research staff. And in rank priority, I would suggest that they are equally placed to the other healthcare workers that are directly interacting with the patients. So Slim, I think that's my only contribution. I agree with what the other panelists have said up until now. Thanks.
Thank you very much, Professor Sun. So I think you've actually expanded some of our frame of reference, because you really now taken that and given it a very broad definition in terms of our community outreach staff for the research, the laboratory teams that are involved. So you've given us a sort of more holistic understanding of who we're talking about in research personnel. And I think you've also captured quite importantly the risks that each of them are at. I mean, no question, people in the lab are at very high risk because they're dealing with live virus. So thank you very much for those very valuable insights. So our last speaker for this morning, I'm going to call on Dr. Mokachane, who is a member of the MRC Bioethics panel, and she's also at Wits University Ethics Committee, and she is a neonatologist and currently is in the undergraduate teaching programs of Wits University. And I have to say something about her, because she's one of those people who has difficulty in not speaking up when she sees some injustice, especially in our communities. So, Dr. Mokachane, it's wonderful to have you. Please share with us your insights.
Thank you very much, Slim. I would also just like to request that I'm going to switch off my video, mainly because of the bandwidth issues. So please, I'm going to switch it off now. Thank you. I must say I agree with all the speakers, what they've already said, and some of them actually stole some of the things I was going to say. I would then start with the question of where does social responsibility for researchers lie? Is it just doing research and publishing results and gaining publications? No, not really. It's more than that. They promote social good. They mitigate against harm through research, through public education, and also advocacy. And I would like to suggest to them that that research team or entity, the person at the top, should actually be looking at the people that are working under them as their own family, their family outside their family. And in African indigenous values, you look after your family. You speak up if one of your family members is not looked after. So I would say they are the ones actually that need to actually speak up and fight for their research personnel. And Dr. Matebula raised the issue of history, antiretrovirals. And I always like going back to it, because I think that's something that taught us, and in South Africa, the challenges that we face. And I think it's something that we shouldn't forget, the mistakes that we made, because if we forget, we will repeat those mistakes. For example, anonymous and linked HIV testing research. I hope I don't make anybody angry. If I do, I apologize in advance. HIV anonymous and linked research continued for too long while masses in the country were dying, and they did not know that they were infected. And they died after infecting many more because they were not made aware that they've been tested and that they are positive. This led to harm to communities, but again to minorities, sponsors and researchers. Apologies, but that's how I see it. So we should also then be looking at guiding principles of how we need to go about this. If you look at the World Health Organization, they're saying they're looking at the human well-being, they're looking at global equity, and we should also, as Glenda was raising, look at regional equity, because we've got our neighbors who will be crossing borders to come to us. Others are working, trying to help all of us. So we should be considering those groups. And there should also be legitimacy in what we do and reciprocity. I really have a challenge with reciprocity. Slim mentioned that the people that were part of the research, there's no question about it. If there is a vaccine that is effective, they need to be getting the vaccine. Is that an African way of doing things? Reciprocity, when you look at it, concerns balanced patterns of giving and taking between people. In African indigenous terms, I find this Western way of doing things challenging and somewhat trumping the African values. Because as an African, if, for instance, I was a participant and there's a vaccine that is effective, I want to be asked for my opinion. Do I want to get, or do I want to recommend someone either in my family or someone that I think needs this more than me to get the vaccine? And I think maybe we should also be changing our way of thinking around this and not just say, participants, you'll get. Ask the participants what they would like to do. So I'm saying give them an opportunity to decide, be part of the decision making. It shouldn't be unilateral. And I would also like to question us against the paternalistic approach of how we're doing things. In some of the questions that have been asked is, should the people then, for instance, with the AstraZeneca vaccine, it should be professionals, or educated people that actually take part in the research, like the healthcare workers. Who should decide that? Are we saying the people that are not educated or not professional, are we saying that they are not able to make those kind of decisions if they're really well informed? I think we need to look at that. Because in a way there is discrimination. We're planning to do good, but sometimes in doing good, we may actually create more harm. Community should also be part of planning everything that we do. And we should engage, we should ask for advice from them, but sometimes it's hard because time is not on our side. But I think they should also be part of discussing what reciprocity means to them. We in the advisory panel, we also are proposing that we should be using a framework for fair, equitable, and timely allocation of COVID-19 vaccines. And we used 4 pillars of that framework. We are affirming humanity for others. There should be social benefit. We should promote common good. We should not discriminate. Sometimes we're not intending to do so, but we do. And we should respect human dignity. And by that, we should also respect their ideas and give them a chance to speak out and decide. The second one, we should make sure that the survival of communities and the researchers or the research personnel also come in here. It's not just the communities that they'll be working in, but themselves as well, because as someone has already said, they're going to be exposed to people that are ill. And they may also have the disease without even knowing that they've been infected. So we need to make sure that our communities survive. There should be social solidarity. We need to create bonds instead of segregation. And if we start saying also that the educated or the professionals should be taking first preference in a way because they'll understand better, already we may be creating cracks and bonding may be a problem there. Lastly, there should be, as I've mentioned before, meaningful engagement with community. Just to also use an example that is usually used in the aeroplane. We do not have vaccines to vaccinate everybody all at once. We have to decide who should be given the oxygen mask first, like we do in the aeroplane if there's an emergency, so that more people could be saved. Using this example then, should the researchers, particularly those doing vaccine research, be regarded as essential workers? Does the oxygen mask rule apply to them in this case? They have to continue doing research, putting themselves at risk, monitoring adverse events following immunization. So we really need to also make them part of those that needs to be getting vaccination first. But lastly, I would like to say, I suggest that then in that research personnel group, it should be a bottom-up access to vaccines. I'm saying the people, as it was being said, the cleaners, those that are going into hospitals, coming into contact with all the various participants, the counselors, those are the people that need to be getting it first, as well as the researchers that are going out in the field. But maybe the PIs, who may not necessarily be in the thick of things, can be getting it last in case there's a shortage. But I hope that the sponsors will make sure that there's no shortage. Thank you, Slim. That's as far as I would like to go.
Thank you very much, Dr. Makachane. It's wonderful to hear the passion and the way in which you articulated it and how you see it in terms of timing. Okay, so what we have is quite a strong convergence of views. Our panelists have come to this issue from differing perspectives, but they've converged around some central issues. So I'll just capture in an abbreviated way the key issues that have been raised. So the first question is that, who are we talking about? The who. And the who is quite a wide definition. People in direct participant contact, individuals who are associated in different ways, whether they are cleaners, whether they are drivers, whether they are doing contact tracing, whether they are seeing patients in the clinic. So the research teams have a very broad definition of all of those associated with it in that way. So that's the first issue, the who. The second was the when. And the when, I heard very strongly, was that the when should be pretty much aligned with the way in which we've been looking at the overall country rollout, which is to be in phase 1, to be right up there in the first group. And the first group in South Africa and the current plan is to give healthcare workers. And so research workers are seen in the same light as healthcare workers. And so in response to the question of when, it would be in the first group that's being vaccinated. The next question was why? And there we came to it in different ways. There's the fundamental belief in saving lives. There was a belief that we need to look after our families. We need to borrow on some of the very fundamental concepts of how we care for each other in African societies. There was the notion of risks that these individuals are placing themselves in. There's a notion of the way in which they contribute. So there was a range of answers to the question of why. And then we answered the question, or addressed the question of how. And on the how question, I think a few of the panelists addressed this question, that we're not talking about taking away the doses, the few doses that we have, or the limited doses that we have for the phase 1 of the rollout. We're talking about the responsibility of sponsors. These are those, whether they are local sponsors or whether they are international sponsors, whether they are pharmaceutical companies or philanthropic organizations or government research funding agencies, that the responsibility is being placed on them, that they have to access the doses and they have to look at ways in which they can provide it to their research teams. And we already heard from Glenda about the way that's already being addressed in some of the international research that's being done. And then finally, the question about, so what are the broader issues? And there, quite importantly, the issue was raised about we can't look at it. This is not a South African only issue. This is an issue that has repercussions well beyond our boundaries and our borders, because there are researchers in various countries. And so if researchers in South Africa are being seen in this way, or we're arguing should be seen in this way, then surely that should apply to others as well. So I'll stop on the note that we have addressed the questions of who, when, why, how, implications, and we've come to the conclusion that yes, research teams should be vaccinated, and they should be vaccinated in the first group by their sponsors, and that applies to everybody who is part and parcel of the research process. So that's where I've arrived to in listening to our 4 speakers. I'm now going to invite all of you, if you would like to make any comments or ask any questions, if I can ask you to please introduce yourself, and then when I call on you, and then to ask your question or make your comment. Okay, so I'll start with inviting Professor Gray. Glenda, over to you.
Thank you, Slim. I just wanted to, so I think there's some clarity around the sponsor. So if you have a vaccine that doesn't work, so say now you're in a study, you were a researcher who participated in a study that didn't show value, yet the research center down the road did show value. So I think we would have to think about that there should be fairness and fairness to access beyond the sponsor for people who were running trials with other manufacturers. So just how would we do? I think we need to think of that we shouldn't disadvantage people in terms of the sponsor supplying the vaccine if it didn't work, but that we had an arrangement that whatever vaccine worked, that in some way the sponsors would work together to supply the vaccine to the staff in some way or the other.
Mm-hmm. Okay. Thank you very much, Professor Gray. Next, I have Daniel Wassenaar.
Thanks very much, Slim. Good morning, everybody. For some reason, my son's name has come up instead of my own. So if I talk rubbish, please blame my son and not me.
So, Doug, are you traveling incognito in this meeting? Is that what it is? Okay.
I always try to do that, Slim.
Go ahead.
Thanks, everybody, for very stimulating contributions. I agree with many of the points, but not all of the points. And what I would like to say is really more of how we should approach the problem. So I'm not going to pretend to be giving an answer to the problem, but rather a method for approaching the problem. Because one of the things I'm concerned about is that very often we have a new ethical problem, and then we think we have to reinvent the wheel, instead of going back to existing guidance and seeing what guidance already exists and seeing whether that guidance is inadequate in some way. So while the people were presenting their very stimulating talks, I came up with the following couple of points as a way of suggesting a way forward rather than directly answering the question. And the first thing is to say, firstly, what does the South African guidance currently tell us about the obligations of researchers for research staff? And in fact, section 1.3.3 already says that researchers have an obligation to protect the interests and the welfare of research staff. So that ethical obligation already exists. I think we should supplement it by looking at what the SA's GCP says. The current version is very out of date, but it's still the legally applicable version, and just to see what obligations are expressed in the current GCP. And then obviously to look at what international research ethics guidance says. And I haven't had time to look at it, but I do remember seeing in international guidance clauses to the effect of the obligations of researchers and probably sponsors to the research team. My third point links very much on a point that Ian Sanne made, and that is that we wouldn't be having this conversation if there were sufficient supplies of vaccines. So we have to take resource constraints upon the table. I think we all agree that everybody would get it if it was universally available, but it isn't available. So we have to have a way of distributing this beneficial resource. And my argument, and I haven't heard it in the conversation so far, except perhaps in Slim's summary, is that I think that the access discussion should be based on empirical risk. What data do we have about who is most at risk? So in the general population, we already know about age, we already know about comorbidity. Then there are certain occupational profiles that are well known, which is why we're also prioritizing health staff. But either we should look at data on how many research personnel have in fact been infected to date. Do we know that? Or should we do a study? Is there time? So what is the profile of the research workers most at risk? And a comment that I think may have been implicit in some of the conversation so far is, remember that this doesn't only apply if we make a recommendation that that vaccines have to be given to research staff. It applies to all non-COVID related researchers as well, people working in HIV, TB, malaria, and other areas. So it's a massive obligation, perhaps not on the sponsors of those studies, but it will have a knock-on effect. So a lot of things that happen, for example, in the ethics of HIV vaccine research, were retrospectively applied to ethics of TB prevention research, of malaria prevention research. So there is a wave, a ripple effect that goes through the research field. And then again, my fifth point in terms of recommending a way forward. So the first is look at the guidance, local and international. The second is what is the risk profile of research workers? Do field workers have more risk than a PI? I suspect they probably do, unless the PI is clinically active. The third one, so look at the risk profile, and then also do some community engagement to see what is expected. But that community engagement must be informed. If you ask communities without some sort of a briefing, communities are clearly going to say, I think everybody must get it. But the problem is that there isn't adequate, so there must be a way of looking at it. So again, I stop there, and it's more of a methodological contribution. Thanks very much, Slim.
Thanks very much, Doug. I like the way you took us back to what the guidance already says, and that was good to hear that. I had forgotten it said that so clearly. I've got next Kathy Slack.
when you are coming through.
Access to COVID vaccine for their study staff. I'm hearing two sort of possibilities. I just want to have an opportunity to clarify about whether we're all on the same page about this. Are we making the argument that study staff should have access to the vaccine that is the experimental product of the trial that they're involved in, which subsequently becomes established as effective? Or are we saying that study staff should have access to a COVID vaccine that is another proven product? So I'm sorry if that's a really stupid question, but I just wanted to clarify what is the exact line of the argument that we're tracing in terms of the product, the vaccine product. Over and out.
Kathy, that's a good question, and I'm going to invite people to want to just comment on that before I take Dr. Matabula. So the question is, because we're talking now about research teams that are doing COVID research. Not all are doing vaccine research. Some are doing treatment research. Some are doing epidemiological research. So the definition is quite wide. And so I don't think we can strictly apply it only to the vaccine being studied, because will only be a small group then. But Glenda, your thoughts?
Yeah, I mean, I agree with you. So I think it won't be the experimental vaccine, because remember, it might not be registered yet, Kathy. And so we would have to get special dispensation if we had to do that. So it would have to be, so the beneficiaries of the first rollout. So I think we would see it in that role, because they take into account people who are working. So not everybody works in the COVID vaccine trials, but people kept the trial sites open. TB research, HIV research, they kept the trial sites open in the surges. And so they themselves, to make sure research happened, availed themselves like the frontline workers. So my suggestion is that all research staff are beneficiaries in the first rollout, in 1A, whatever you want to call it, and that they are considered frontline workers because of the work they've done in the laboratories and during the surges to keep research going in South Africa or in Africa or in Latin America.
Yeah. So Glenda, thanks for that. I agree with that latter argument. I think it's sounder, but I was just starting to hear traces of the other argument in some of the former discussion. So thanks very much.
I did a bit of lip reading there, Slim. You were mute. So, yes, I think, thank you, Glenda. That's very clear. Researchers, we cannot afford to take our eyes off the ball. When we think COVID is the thing, TB will kill a lot of us. When we think COVID is the thing, other childhood diseases might actually spread out and begin to cause havoc. So it is not, those researchers will always be on site to ensure that work continues in those fields. So it's researchers in general. And I think for me, the debate or the discussion today is actually to focus on the justification for having researchers having access in the first round, because I'm sure we cannot agree on who should go first. What comes to my mind right now is the movie Titanic. You know, things are falling apart, and who gets that boat to safety first? You know, and you think the captain remains, and he says, you know, it's my responsibility to make sure that everybody is comfortable, and he sits there and they play a beautiful piece. But on the other hand, there are people who feel they must go in first. So that argument will always be there, and it will always be a difficult one. That is why I think we need to step back and say, will it be fair for us to ask the sponsors to actually take responsibility to keep the people on site, and not only people who are working in this particular field of disease, COVID, but just researchers in general. Thank you, Slim.
Thank you very much. My apologies in not unmuting myself, but just, you know, as you spoke, I had sort of visions of the movie and was trying to wonder who would be, you know, the quartet that would just stay on board, try and keep people cheery while those who wanted to be rescued got onto the boats. And I was just thinking that the one issue we haven't touched on, what would happen if you have a research team that's doing multiple different studies? Some are working on COVID, some are working on HIV, some are working on TB, and would just the COVID teams get the vaccinations? What about all the others? I just thought about that briefly, so I don't have an answer, but I'm going to ask two people to comment on that, if I might. I'm going to ask Linda Gale Becker, and I'm going to ask Jerome Singh to get two differing perspectives on just that question. Linda Gale? Okay, I think she might still be muted. Jerome?
Okay, dropping on me suddenly, Slim, but I think my quick answer would be...
Jumping on you.
Yes, I didn't prepare anything, but my quick question would be, what is our understanding of altruism? And, you know, altruism is a very different concept from beneficence and a very different concept from other things. Altruism means making a sacrifice for others at a cost to oneself. That's what true altruism is. There are many other different definitions of altruism, but the original altruism is I take a knock for the team because it's good for them and not necessarily because it's good for me. So I think it depends on whether you see investigators and researchers as being altruistic in their conduct, or are they doing this for a job? Now, sometimes people, when they're working in the humanitarian field or they're working in the health field, they take on a health duty because they feel it's their calling, as the old words used to be called. It was their calling. And so they would be actually running towards the fire, not away from the fire, like a firefighter. So I think, you know, in this context, if you're looking at a healthcare worker and you're looking at the wider field of health researchers, are health researchers in this because they are there to help others, or are they in this because it's their job? And I think you'll find that there's a wide range and a combination, and there's a wide spectrum of how this is. But I think the short of the long here is that if you believe in altruism, you will be the quartet on the ship. And when everybody else gets it, that's when you feel you'll get it. The counter argument would be, well, if we all die, then who's going to be, of course, playing the quartet? Who's going to be the quartet if we all die? So I think, you know, the issue here is that it must be formed on a rational basis. It must be done on the basis of, I totally agree with Doug, you know, what is the evidentiary base? Because there are many, many different categories of health workers, and there are many different categories of researchers who are involved in health. And I think if you're looking at researchers, the team is much, much bigger than health researchers in the typical biomedical sense. So what about those people who are doing qualitative research? They're sitting in a very closed room, doing one-on-one interviews. They're sitting and doing focus group discussions. So, you know, there's a lot of risk for those people as well. So I think if you start looking at those categories, it would be an interesting exercise. I don't think we have, you know, any stats, SA stats, or any sort of collective amount of how many researchers we have in South Africa. But I'm supposing that this grouping is not just clinical investigators, but we're looking at all health investigators or all health researchers, because that team is very big. And, you know, and I think that it gets much more complicated because you get some researchers who sit in the offices. They don't encounter staff. They may be, for example, data capturers doing very important research. You may be a manager. You don't go and interact. But I think, you know, you may interact and you may be exposed in a secondary sense to risk because you're interacting with those who are, in fact, meeting other people, but then the same can be said for their families. So, you know, at the end of the day, if you are going to be a manager and getting this vaccine when you don't interact with clinical patients or with research participants, why should you get it? Because in that case, those who are making direct contact with patients or with research participants and who are at risk, their families must get it above you. So, you know, I think it does get a bit more complicated. So I'll stop there. I don't want to hog time, but thanks for asking the question. But that's my very quick take on it.
Great. Thanks very much, Jerome. I appreciated the way in which you articulated it, and you've given us a sort of additional dimensions to the issue. I'm going to check if Khatija Ahmed wants to add anything.
Hi, thank you, Slim. I was just about to put my hand up and you called on me, so there's probably some telepathy going on here. Can you all hear me? I see Slim is frozen on the screen.
Yes, we can hear you, Khatija.
We can hear you.
Okay, thanks, Matsonso. Okay, so I am really, I totally agree. This is critically important that we have this roundtable discussion. Maybe it's even a little bit later than what we should have. And sorry, there's a lot of background noise. Thank you, everyone, for muting.
My apologies.
I think that we definitely need to have a plan in place, and I think this should be our focus at the end of this. We need a planning committee to decide in terms of the database of all researchers in South Africa, and maybe, as Glenda even said, our neighboring countries, to decide we're going to need a rollout of, for example, 500,000 vaccines or 200,000 vaccines to cover all the researchers. And then we're going to have to discuss in terms of how we're going to access that vaccine, which would be the most important, which would be the best vaccine to roll out, as well as in terms of how we're going to finance it, because I think we're all well aware that the resources, financial resources are very low. And I'm sure as research organizations, we can help to finance our research staff's vaccines. So, and then, of course, as many have said already, to prioritize in terms of who should get the vaccine. So, for example, in a research organization, a driver or a cleaner would be critical as frontline workers rather than someone that sits in the finance office to get the vaccine. So I think we need to then also categorize how to roll out those vaccines within the research centers. Thanks, that's my 2 cents, but can't hear you, Slim, you're on mute.
Sorry. My apologies. I seem to have got dropped off the call, but I got most of what you said, Khatija. Thank you very much for highlighting, what are going to be quite significant logistical issues that we're going to have to grapple with in dealing with this issue. I want to see who else has a hand up. Kathy, you have a hand up. Is that an old hand or is it a new one?
Apologies, Slim. It was a new one.
Okay, please go ahead.
I just wanted to circle back to something that Jerome and an earlier speaker was saying. There seems to be 2 lines of argument that we could help to identify various subgroups within the overall group of study staff. Some seem to be arguing that risk is the sort of the issue that's doing the heavy lifting. So risk of COVID acquisition. And the other one seems to be a little bit more on contribution. So even if you are not at risk, you're still contributing to research in the country. And I think there's probably no reason why the drafters of the guidance couldn't invoke more than one principle when they're trying to make some subcategories of study staff come out into relief, whereas others are more in the background. That's all I wanted to say.
Actually, I like the way you categorized it in that way. It helps clarify the who question a little bit better. Thanks very much, Kathy. Neetha Moran, you up next.
Hi, thank you very much, and thank you to the panel. So my comments are 3 based on the issue of shortage, and I see this as an interim initial plan. The one is that I'm sure we have epidemiological data indicating from all the research institutes which category of staff were infected and exposure. And I haven't seen that data. My social media information explains to me the medical doctors and the nurses most affected in hospital settings. So I think that data may inform us. The second is that I want to go back to one of the panelists who said about our individual ethical behavior and altruism and the Titanic. So for example, if I am as a researcher, I'm aware I'm not directly affected, I can have a choice and be altruistic and say, I will wait my turn, as said by Gates. And I think that's important, because what is our individual ethical behavior as researchers, and make that choice or offering that I can wait my turn within the research team. The last comment I want to make from in this panel is that it would be really valuable for us to get participants and community feedback. For somebody who worked in community for decades, I'm aware that if I went with this issue with them and they're highly literate, they would guide me and want to protect the researchers who have been giving them healthcare benefits, information on HIV, TB for decades. And so it would be valuable to have those participants and community share on this panel their views on some of the ethical considerations. Thank you.
Great, thank you very much, Neetha. I like the way in which you articulated the additional dimension that, in the face of altruism, people can say, I think others should get it first. And so even though they offered it, they don't have to take it initially in the interest or in their own broader interests of the community rather than their own. I'd like to give everybody a chance to ask any last questions. And I'm going to then invite the panel members to make some parting comments before I invite Amos Dai to summarize and give us, a way forward. Dr. Makochane, please go ahead.
Thank you very much. It may not necessarily be part of this discussion, but I'm still concerned that there's a group that is not really classified as healthcare workers, and those are priests. We put in traditional healers as part of this, but I don't see priests anywhere. And they are helping in the community. When people have other health issues, either emotional or otherwise, they go to priests. And I don't know who will take this up. I think the priests should actually be added as well. Thank you.
Okay, so you should know that the priests have already taken it up and have asked to be categorized in, I think it's phase 2. So that's already, or phase, I can't remember now, but that's already under consideration. But good point. All right, so I'm going to, I don't see any other hands up. I'm going to invite each of our panelists to make some closing remarks. And it can be as short or as long as you like. And then I'm going to invite Professor Dai to wrap us up. Okay, so let's start with Professor Gray, if I can invite you to make some closing comments.
Thank you. I mean, I think this has been hugely informative and much needed, and helped us frame the debate and the challenge that we face as scientists, both in South Africa and elsewhere. I see we have Elizabeth also from Kenya, who's was on the call. I think she's still on. And so these deliberations might help other colleagues in Africa. So I do think I agree with Khatija on the way forward, is that we do need to maybe develop and maybe this is where Jerome and Ames and Khatija, I mean, we should come up with a position statement on this, so that we can put forth this debate, because it's not happening anywhere else. The debate has originated in South Africa, maybe because we find ourselves between the cracks. So I think it would be great to come up with a position statement on this urgently and put it forth to the global community.
Great. Thanks very much, Glenda. Next, I'd like to call on Dr. Matabule. Dr. Matabule.
Thanks, Prof. I think the engagements were very useful, and I just want to make one comment, and that is the struggle to find who qualifies first will always be something that's on the table, because everybody will present their own reasons. And as researchers and health workers, we always want to put others before us. But what is the wisdom when it comes to determining whether or not making sure that researchers benefit directly? I think if we find let me state it this way, if we can find a parallel way of ensuring that researchers also benefit from getting a product that works, and we leave government to attend to the rest of the community, I think it would sort of mitigate the who comes first question.
Absolutely. Thank you very much. Okay, next I'm going to ask Professor Yan Sang.
So thanks, Lim. I think it's a super interesting debate. I do think that we need to consider the research impulse as an alternative career pathway for healthcare workers, and not as a group of self-edifying researchers. The people that we engage, the clinical teams that we engage, are critical to moving forward the potential solutions both in prevention, vaccine, and in treatment. And I would think that one of the elements that we haven't discussed today is if these early access programs are initiated, whether informed consent can include the parameters to cover what would be potentially a concern about subordinate research. So is the participant actually a subordinate to the early access program or to the researchers? But overall, my parting comment would be, as an employer, as the senior person, I do feel a deep sense of responsibility to ensure the safety of the staff, and would suggest that the safety of research staff meeting with known positive COVID participants in this instance, is equal to the risk in a hospital setting, as we make the diagnosis, staging of disease, and potentially providing treatment to those participants. Thanks, Lim, and thanks, Ames, for organizing a great session.
Great, thanks very much, Professor Sane. Okay, I'll take the last comments from Dr. Makochane.
Thank you, Slim. Thank you very much for inviting us to take part in this. There was a question that I was asked to address, and I don't think we were able to do that. I hope it doesn't create more debate. Maybe we'll be able to close. The question was, with the latest developments on the South African variant and the AstraZeneca vaccine use being put on hold, could these be used in the context of well-designed studies with highly motivated and literate participants like researchers and other professionals? I've already mentioned the issue of paternalism here, that we shouldn't be deciding for them like that. But again, maybe they should be used that way. But then people should actually be clear. We should be taking 3 points into account. Rationality. Does one have good self-regarding reason to subject oneself to medical experiments? So if really they are clear on that, then it's okay. And also justice and fairness. Does one have duty or an obligation to take part in experimental medical research? So if they want to do that, knowing this, it's also okay. And the last one is virtue, or just mainly for charity. We are in trouble, and we need to get as many vaccines as we can that are effective. So maybe some people can use this to say, I want to get involved in that and give me an opportunity. Thank you, Slim. I'll end there.
Great. Thanks very much. Interesting twist and a perspective. Okay, on that note, I'd like to invite Professor Dai to give us a synopsis and a way forward.
Okay, so I think this was a very fruitful roundtable, and I want to thank all our panelists and our chair for agreeing to participate. And I also want to thank the members, delegates that have attended and contributed as well. I think what's come out is this is a critically important issue. And it is something that maybe we should have thought about already. So that for me justifies or makes me feel good that we have embarked on the right road. And this was actually repeated by panelists and by the discussants. What's also come out is that researchers also place themselves at risk for the greater good. And while the situation is clearer for research participants, it's not that clear in terms of researchers. And the whole issue of who should be included in terms of the research personnel was also unpacked. And we got a clearer view as well that it should involve the lab staff, the NPOs that are involved as well. So it is a very broad range of people. And then the question on, should the discussions just be risk-based, or should it be a combination of risk and contribution based? And I think that is an important question that the ethicists and researchers need to work out together in terms of planning a way forward. Slim talked to us about the convergence of views, and he did it very succinctly: who, when, why, how, and also the broader issues. And we haven't spent much time on the broader issues in terms of our collaborators across our borders, but they are essential to what we do, and they should not be left out of the equation. In terms of what the responsibility of the sponsor is, the responsibility of the sponsor ought to be an effective vaccine that is registered for country use. So it's not whether the vaccine worked or did not work in his or her trial, but it is an effective vaccine for country. Doug brought us back to basics, where he said, look at ethical guidance that already exists. And in terms of South African guidelines, for sure, researchers have to have an obligation to take care of their research staff. Now, this is researchers. Do we lump researchers and sponsors together? Or do we say to researchers, you've got an obligation to look after your research staff, so go to your sponsors and advocate so that you can take this obligation forward, because our researchers have an advocacy role as well. Now, there were questions about altruism, and it was stated very nicely. I think it was Nita who said that, yes, the demand actually outstrips the supply. So as altruistic researchers, we should look at, we have a choice as to whether we go first in terms of the research, in terms of who gets it within the research context, or we wait for others to actually get it before us. And I think that's a very good way of looking at it as well. Very important also, what came out was looking at communities and engaging communities in these discussions, because in all research that one does, major research of this nature, community engagement is so important. And it's important to legitimize the process, because we wouldn't want communities to end up feeling that here we have a group of elites. And I think the discussion should also go as far as we do have select community groups within different research sites. There's community engagement before we do research. So do we include them in that list of research personnel? So we've got to do a lot of community engagement there. And then, of course, Khatija brought us down to earth to say, yes, there's a lot of discussion. We have a convergence of views. There are significant logistical issues. So she suggested a planning committee. Glenda also suggested that we come up with a position statement that we can put forward to the global community, because it hasn't been done first. So,
yeah, no, I'm joining a meeting. Okay, all right. I'll talk to you in the afternoon. Right.
Hello, please go on mute.
Please mute.
So whose responsibility would it be to come up with that position statement, and whose responsibility would it be to take that planning committee as proposed forward? And as the MRC, okay, we, the Bioethics Advisory Panel, I'm going to throw the ball back to Glenda's court. Glenda, we convened this roundtable from your offices as your panel. So should the Bioethics Advisory Panel come up with this position statement, working with our other researchers on this panel and on this call? And should we do the same for planning, for the planning committee? Should the SAMRC take the responsibility to convene the planning committee? So I'm going to hand over to you, Glenda, to respond to that and to close the meeting.
So thank you. I was just going to say, as long as it's not me that's responsible for this, because I can't take any more responsibility for anything. So Amos, I'm happy for the MRC BAP to take the lead and work with the researchers who are interested to come up with a position statement and a working document that I guess we can all endorse. Because I think the MRC can convene, but it also would be very important to get all the individual research institutes, the Caprices, the Right to Cares, the MedCrew, the all the Khadija's, SRC, all the research institutes in South Africa that have contributed for decades to actually improving the lives of people not only in Africa but across the globe. And it also would be nice to add the KEMRIs and the other collaborators outside South Africa as a novel way to move forward from the African continent. So I would say that we can be convening. I'll throw it at you. They will have to add some more hours to your to your work with us, and then ask the MRC BAP to take the lead and help us, because I think a lot of the researchers are a bit overwhelmed now and need hands on deck here.
Okay, thanks, Glenda. And of course, we had Slim who very graciously agreed to chair this roundtable. So I'm going to suggest that, we maybe spread this beyond the MRC. We'll take the lead, but we're going to consult with the different research heads, and we'll ask Caprisa to assist with taking a lead on this as well. Thank you.
Well, thank you very much, everybody. Great having you. Thanks to Glenda. Thanks to Matsonso and Ian and Mantoa. It's great to have you all in this panel. And I want to thank Ames for pulling it all together. Great job, and have a wonderful rest of the day. Thank you and bye-bye.
Thank you very much.
Thank you very much.
Bye.
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 Yes.
Bye.